Velu?
మేడం గారు
చెప్పండి.
మేడం గారు ఈరోజు నేను
Ma'am, good evening. Good evening.
Sir.
Good evening, Dr. Padma ma'am.
Yeah, good evening.
Ma'am, this is Saurabh Sharma from the marketing team of Shield Healthcare.
Oh, nice
Thank
to
you
meet
very much.
you.
Thank
Nice
you.
talking to you.
Yeah.
Yeah.
Thank you very much for being the esteemed faculty of today's webinar, ma'am. It's a pleasure, privilege to have you on.
It's my pleasure.
Yeah. Ma'am, what we will do is, I think our medical team, Dr. Stalin is also there. Hi, Dr. Stalin.
Yeah, good evening, Saurabh.
Good evening, Stalin.
Yeah.
So, madam, what will happen is we will wait for another 2 minutes after 5:30. We will begin around 5:32. That is 7 minutes from now. And Dr. Stalin will welcome you and the audience. Okay.
Okay.
And
I don't see any audience so far.
Ma'am, in this, yeah, very right, ma'am. Ma'am, this is actually a different chat room. Or this webinar is being broadcasted via our website Shield Connect. Okay.
Okay.
So you won't be able to see any audience, but there are audience who are watching this. They have a different link.
Okay. I won't be able to see them. Okay.
No, ma'am. So what will happen, ma'am? Dr. Stalin will post in the questions coming from them after the program. Okay. So we will run. We will welcome you, and then we will have a short AV presentation of Shield Connect, and then followed by your presentation and the question and answers.
Yeah,
Right, ma'am?
Sure. No problem.
Thank you, doctor.
Okay.
Even there. Yeah, good evening. Yeah. Good evening, ma'am. Dr. Ranja, ma'am.
Professor sir, good evening.
Good evening. Good evening.
Sound echo voice.
Echoes. Let's check. Let me check. Yeah, I'm audible now.
Yeah.
Yeah, all right.
So, ma'am, we can start the session, ma'am.
Okay.
Yeah, ma'am. Very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. Topic for the day is intrauterine insemination. Can we increase the success rate? I kindly request the participants to post their queries in the comment box. At the end of the presentation, we'll be having a short Q&A session. And now it's time to introduce our eminent speaker for this evening, Dr. Sajja Batma. Thank you for accepting our invitation, and it's an honor to introduce you, ma'am. Madam has completed her MD OBG from Osmania Medical College, Hyderabad. And Madam is currently the Managing Director of Pragati IVF and Laparoscopic Center, Rajahmundry. Madam has undergone IIT training in MS Medical Center, New York, and also in National University, Singapore. Madam is a member of several associations like American Fertility Society, ESHRI, FOXY, and IMA. With this introduction, I welcome you, ma'am, and request you to take over the session, ma'am. Madam, before going to the session, we are launching our Shield Connect web page. I request you to allow me a 1-minute video.
Sure.
Yeah, ma'am. Swear about you. Shield Connect is a new initiative of Shield Healthcare, ma'am, and it is a digital platform with all updated informations. All our webinars are conducted through this Shield Connect platform, and it has blogs, scientific materials, and all updated informations for women from. Uh, and you can find the videos of past webinars in this page, ma'am, and you can also find the informations of coming webinars. I request the participants to go through the web page for all updated information. And thank you, ma'am, and over to you, ma'am.
Doctor, you have to unmute yourself, ma'am. Madam, please unmute.
Oh, thank you, Dr. Stalin, for giving such nice introduction. And also I thank Shield Pharma people for giving such excellent academic support to the doctors. And am I audible clearly?
Yeah, doctor, very much.
Okay, then. So shall I share my screen now?
Yes, ma'am.
Are you able to see my screen?
Yes, doctor.
Okay then. So good evening, everybody. And today I'm going to speak about IUI. Can we increase the success rates? This is often asked question in the field of ART. And IUI is one of the oldest and most popular techniques used to treat subfertile couples, and it involves deposition of the processed semen sample into the uterine cavity at the time of ovulation. And the first report of IUI was published by Cohen et al. In 1962. Since then, the success rates of IUI have gone up from 5% to 20% because of the tremendous changes in the stimulation protocols, timing of the ovulation, trigger mechanisms, and monitoring of the cycles, semen preparation methods, and luteal support. And IUI with ovarian stimulation has become first modality of the treatment offered to many infertile couples nowadays. And why IUI is so popular? It is inexpensive, needs less medication to the female partner, and less monitoring and hospital visits for the couples, and is associated with less complications to the patient, and it is associated with less psychological burden as well as financial burden to the couples. And from the physician's perspective point, it has very easy learning curve and needs less establishment charges. In spite of this popularity and simplicity in the technique and minimally invasiveness, but still IUI not considered as an effective tool to be offered to the subfertile couples by many of the physicians. And IUI, the use of IUI as the first line of therapy has remained controversial until recently. That is because of lack of prospective randomized control trials and large prospective cohort studies linked to the low budget allocated to IUI trials when compared to large multicentric trials with high budget supported by big pharmaceutical companies in the field of IVF or ICSI technologies. That means due to lack of randomized control studies and large prospective cohort studies, IUI has taken back seat in the field of ART, and it is not considered as a prime modality of the modality treatments till recently. And the Ishri Capri workshop in 2009, the conclusions given in that workshop were, for good prognosis couples, live birth rate is better without any treatment. That means expectant management is better in comparison with IUI for good prognosis couples. And though IUI is cheap and less demanding, IVF is more effective. And to get modest benefit, IUI needs ovarian stimulation with associated risk of high number of multiple births. That means it's no more than a poorer substitute for IVF. Means in previous past studies, IUI, the results shown with IUI are very poor, and also it was shown that an association of high incidence of multiple births with IUI procedures. And NICE guidelines published in 2013 recommended that in case of unexplained infertility with failed expectant management for up to 2 years should be followed by IVF directly, suggesting bypassing IUI, suggesting IUI has got limited role in the field of infertility. And this has created a lot of controversy regarding the role of IUI in the field of subfertility. And NICE guidelines were based mainly on few studies like Bhattacharya et al., studies done by Bhattacharya et al. With obvious shortcomings. And these studies didn't take into the consideration of HFEA data, which showed that average pregnancy rate of UK during the same period, that is 2011 to 12, is around 13%. So Bhattacharya et al., they didn't take into the consideration of HFEA data during the same period, which was showed as 13% in UK. So despite these guidelines, 90% of the clinics in UK continued to offer IUIs to the couples. So since that, number of randomized controlled trials have been published supporting the value of IUI, and multicentric randomized study in Netherlands showed that non-inferiority of IUI with ovarian stimulation when compared with IVF with single embryo transfer and IVF in natural modified cycle with reasonably low multiple birth rates. And since then, so because of low healthcare costs in unexplained infertility and mild male factor, IUI has become the treatment of choice than expectant management. Cindy Farker again in 2017 showed the result of a randomized control study, which included 201 couples with 3 to 4 years of unexplained infertility who have received 3 to 4 cycles of IUI on one arm and expectant management another arm randomly, showed that live birth rate in IUI group is around 31% when compared to 9% in expectant group. So now IUI in many centers is being offered as a prime modality of the treatment for unexplained infertility. And the prerequisites of IUI, and there must be ovulatory cycle, and there must be at least one patent tube, and total motile sperm count ideally should be more than 10 millions per ml. And what is the rationale of IUI with ovarian stimulation? IUI with ovarian stimulation has three important components, that is which help in improving the pregnancy rates. One is semen preparation. Semen preparation, we know it selects morphologically normal motile sperms, highly motile sperms and capacitated sperms, and removing the debris, prostaglandins, leukocytes, antigenic proteins from the seminal plasma. So which gives us highly motile, morphologically normal, capacitated spermatozoa after the semen preparation. And the media used provides nutrition to the spermatozoa and improves the motility of the spermatozoa, and it helps in capacitation also. The second component is controlled ovarian hyperstimulation, which means which can give us more number of fertilized oocytes, that is 2 or 3 follicles for the ovulation, during the ovulation, and which can means more number of fertilizable oocytes are available at the time of ovulation. And we have more number of follicles means a good amount of estradiol in the circulation, which can correct certain endocrinological disorders, and it can create good endometrium, and which can again correct certain luteal phase defects in the post-ovulatory period. And also we can time the ovulation accurately with ultrasound monitoring during controlled ovarian hyperstimulation. And third part is deposition of the prepared semen sample directly into the uterine cavity, bypassing the cervical barrier, and also certain anatomic defects. And also we can increase the density of the spermatozoa, which is available to the oocyte, and we are depositing spermatozoa as close as possible to the oocyte. So that is the advantage of intrauterine insemination. Coming to the indications of IUI, and we all know physical or psychosexual problems in the male partner, that is hypospadias, erectile dysfunction, retrograde ejaculation, and vaginismus in the female partner, and in HIV discordant couples. And infertility factors like unexplained infertility, mild to moderate male infertility, minimal to mild endometriosis, anovulatory infertility, unilateral tubal disease, cervical factor. And coming to the donor insemination indications, azoospermia, and when there is severe asthenoteratozoospermia, when couple cannot afford ICSI, and when there is inheritable genetic disorders in the male partner, when the couple is lesbian and the female is single. We can offer donor insemination in these situations. Absolute contraindications, pelvic infections, and endometritis. So now we are going to discuss about the factors which can influence IUI results. Patient characteristics, like I'll be going through all these slides and the later slides. I'll be discussing about these factors. First, I'll list out the factors which can influence the IUI success rates. Age of the female partner, BMI of the female partner, duration of the infertility, infertility etiology, whether the infertility is associated with single or multiple factors, and number of IUI cycles, quality of the semen sample, and whether the cycle is natural or stimulated, or whether ovarian stimulation is done by oral ovulogins or gonadotropins, and type of gonadotropins being used, HMG or FSH, recombinant or urinary FSH or urinary HMG, and type of gonadotropin protocols, whether it's step-up protocol, step-down protocol, or combination protocols, and timing of HCG, type of trigger agent, and timing of insemination, number of inseminations, type of semen preparations, type of catheter, technique of insemination, whether rest is to be given after insemination or immediate mobilization is can be advised, and regarding luteal phase support. All these factors we are going to discuss in the next following slides. Coming to the age of the female partner, age of the female partner is the single most prognostic factor which can affect the results of IUI, for that matter any ART procedures, and clinical pregnancy as well as live birth rates decline after the age of 35 years. We all know about this. And 40 trial, that is 40 and over treatment trial done by Merlin Goldman showed that older women between 38 to 42 years with unexplained infertility achieved pregnancy with immediate IVF cycles rather than IUI with controlled ovarian hyperstimulation in fewer cycles. That is, in this age group, IVF is more effective than IUI with ovarian hyperstimulation, controlled ovarian stimulation, making IVF cost effective in this age group. So this graph is indicating likelihood of getting pregnancy with the age and likelihood of infertility with the age. So hence in women over 38 years or older, advice should be given to consider IVF directly whenever possible. If because of financial reasons, if they opt for IUI, that is acceptable. But if there is a possibility, we have to advise them to go for IVF directly after the age of 38 years. And pregnancy rates in 40 trials are as follows, and 6.9% with the CC plus IUI, that is between 38 and 42 years, 7.7% with the gonadotropins and IUI, whereas in IVF the pregnancy rates are about 27.4%. So that means effective treatment in this age group is in favor of IVF. So regarding BMI, female obesity is associated with poorer reproductive outcomes. We all know about it, and then it is associated with increased incidence of pregnancy losses, and also it is associated with medical disorders complicating pregnancies. But to date, there is no data suggesting high BMI reduces IUI results. Coming to the duration of the infertility, longer the duration of infertility, less will be the results of IUI. Hansen et al. Published a paper in fertility sterility regarding the predictors of pregnancy and live birth rate in couples with unexplained infertility following ovarian stimulation intrauterine insemination. In that, they've showed that duration of more than 5 years of infertility, IUI results are less. Again, this graph is showing pregnancy rates and live birth rates decreases with the increased duration of infertility. So also abortion rates increases with the duration of the infertility. Coming to the infertility etiology, careful analysis must be done regarding etiological factors behind the subfertility of the couples, so that we can guide them in a proper manner, whether to go for some expectant management, whether to opt for IUIs, or whether to go for IVF management directly. In general, couples with secondary infertility do better than primary infertility as expected. 21.4 versus 9% pregnancy rates are observed in couples with secondary and primary infertilities. And couple with multiple infertility factors have fewer chance of pregnancy with IUI than with a single infertility factor. That is also expected. So whenever we see the couple with the multiple infertility factors, better we advise them to go for advanced technologies like IVF or ICSI, rather than giving the option of IUIs or expectant managements. Coming to the unexplained infertility, we have already discussed about this factor, and the recent guidelines given by ASRM practice committee showed that the treatment of unexplained infertility is by necessity empiric, and for most of the couples, the best initial therapy is the course of 3 to 4 cycles of ovarian hyperstimulation with oral medications and intrauterine insemination, followed by in vitro fertilization for those who are unsuccessful with IUI and OS. So that means initial therapy should be offered in the form of IUI with oral stimulation with oral medications for at least 3 to 4 cycles. If they fail to succeed in with the treatment of IUI and OS, then they can be offered in vitro fertilization. Coming to male factor infertility, when semen parameters like count, motility, morphology are mildly compromised, they can be treated with IUI. But when there are severe defects or multiple severe defects in the semen sample, they can be directly, offered advanced technologies like IVF or ICSI. And ideally, the severely compromised parameters means when the total motile count of less than 5 million per ml, when the morphologically normal spermatozoa percentage is less than 4%, and when the total inseminate semen count is less than 1 million, total motility in the native sample is less than 30%. These are all the when these factors are present, we can say the semen parameters are compromised. In this situation, we have to offer the mixing instead of going for expectant managements or IUIs. Coming to DNA fragmentation index, and DNA fragment, some of the studies showed that DNA fragmentation index more than 30% is also associated with the decreased success rates with IUIs, but it can give only prognostic, acts as a prognostic factor, but we cannot predict pregnancy outcomes with the DFI. Level C evidence to predict pregnancy rates with the use of DNA fragmentation score. Hence, we do not recommend routine use of DNA fragmentation index in IUI cycles. And this study is showing that less than 15% DFI is associated with the pregnancy rates of 41%, and more than DFI is associated with 22% of pregnancy rates. That means that's almost 50% drop in the pregnancy rates when the DFI is more than 30%. Regarding anovulatory infertility, anovulation per se is not an indication for IUI, but most of the times OS is combined with IUIs to improve pregnancy rates, because we want to have good pregnancy rates, so we'll combine IUI also with ovarian stimulation. And clinical pregnancy rates per cycle is around 11 to 20% in anovulatory infertility, and multiple pregnancy rates are about 11 to 36%. So current recommendations suggest IUI should not be the first line of treatment for anovulation. Coming to endometriosis, in stage 1 endometriosis, IUI with ovarian stimulation is an effective therapy to improve the pregnancy rates than expectant management. IUI with gonadotropin ovarian stimulation is much more efficient when compared with oral ovulogens in giving good pregnancy rates. So it improves almost like, increases almost like 3 to 4 times than expectant management. IVF is a better choice in stage 3 and 4 endometriosis, and also after 3 cycles of IUI in stage 1 and 2, and especially if it is associated with compromised tubes, decreased ovarian reserve, and the male factor is associated when there is advanced female partner age. So in this, when these factors are present along with stage 1 and 2, again we'll consider doing IVF directly, and also stage 3 and 4 directly we should consider doing, we should give the option of doing IVF in these couples. And regarding cervical factor infertility, IU is an effective treatment in cervical factor problem, and pregnancy rates expected are 51% versus 33% in couples with isolated cervical factor hostility when compared with expectant management. Tubal factor infertility, in unilateral proximal tubal occlusion, IUI plus OS can be suggested, and the cumulative pregnancy rates are less than unexplained infertility. And regarding number of insemination cycles, again, this is often asked question in the field of infertility, often discussed question in the field of infertility. 4 to 6 cycles in properly selected patients may be performed with reasonable pregnancy rates, because up to 6 cycles, IUI is still cost effective than IVF. And if you look at the data, we can find two relevant studies regarding the number of insemination cycles. One is published by Custer et al. In 2008. It is a retrospective study involving 3,714 women undergoing 15,303 cycles, and analysis was done up to 9th cycle of IUI. And ongoing pregnancy rates and cumulative pregnancy rates are as follows. In first one and two cycles, the ongoing pregnancy rates were shown as 7.4%, and in sixth and ninth cycles, the ongoing pregnancy rates dropped down. It was shown as 4.7%, indicating that in next first three cycles, the pregnancy rates are around reasonable enough, and pregnancy rates drops down with the increased number of cycles, but the cumulative pregnancy rate after 9th cycle was shown as 41.2%. And in another prospective observational study done by Abulgar et al. In 2001 showed that the clinical pregnancy rate is significantly higher in the first three cycles compared to next three cycles. That means the inference is the IUI results plateaus after 3 to 4 cycles. And after 3 to 4 cycles, the results will come down when compared with first three cycles. So careful evaluation must be done. That means we have to reassess the male factors like age, ovarian disorder, male factor, duration of the infertility before continuing treatment beyond 3 to 4 cycles. And coming to ovarian stimulation protocols, unless patients request or when there are factors like physical or psychosexual factors in the male partner, generally control ovarian stimulation is combined with IUI to increase the number of fertilizable oocytes to get optimum results. So the drugs available are, we all know, oral ovulogents like clomiphene citrate, the dose being anywhere between 50 milligrams to 200 milligrams given for 5 days, starting from day 2 or day 3 onwards. And the doses can be extended up to 10 days in resistant cases. But ideal doses suggested is 100 milligrams for the fear of causing anti-estrogenic effect on the endometrium and cervical mucus. And the ovulation rates expected from clomiphene citrate are 74 to 76%, and clinical pregnancy rates are about 8 to 9%. Next drug is letrozole. This is aromatase inhibitor drug, competitively inhibits the enzyme aromatase, and the dosage is around 2.5 to 7.5 milligrams for 5 days. Again, so we can start the doses from second or third day onwards, and it can be extended up to 10 days in case of poor follicular response. And ovulation rates expected are 80 to 82%, and clinical pregnancy rates are about 12 to 14%. And this letrozole is supposed to induce monofollicular growth when compared with clomiphene citrate, and also it has studies claim that it has more favorable effect on the endometrium, but in practice we don't see much difference between the clomiphene and letrozole in terms of ovulation rates and also effect on the endometrium and clinical pregnancy rates. Tamoxifen is the selective estrogen receptor modulator. The doses can be 40 to 80 mg for 5 days. This can be used again in CC resistant cases, and it shows favorable effect on the endometrium. Whenever thinning is, if you think thinning is happening because of CC, we can switch over to tamoxifen to prevent the anti-estrogenic effect on the endometrium by clomiphene citrate. Coming to gonadotropins, we have HMGs and FSH preparations. HMG has equal amounts of LH and FSH. It is available either in the urinary form or highly purified form. And coming to FSH preparation, it has only FSH with varying degree of purity. It is again available in the urinary preparation as highly purified form or in the recombinant form. So coming to gonadotropins regimens in IUI, popular regimen is combination of oral ovulogents and gonadotropins, which is given as, that means oral ovulogents and gonadotropins are given in sequential manner. Initially, we start with CC 100 milligrams, letrozole 5 milligrams, and combine gonadotropins in the dose of around 75 to 150 IU from day 7 onwards. And depending upon the follicular growth, we continue up to the follicular maturity. And Cochrane review says giving the gonadotropins in continuous manner is better than intermittent fashion. And coming to gonadotropins only regimens, we start generally gonadotropins from day 2 or day 3 onwards. And various proposed doses of gonadotropins are given in this table. In PCOS, we start with less dosage, especially when the age group is less than 30 years. We start with 37.5 to 75 U per day. In normal responder, we give 75 U, and poor responder, we can give 150 U even if the age is less than 30 years. Between 35 and 30 and 35, 75 U in PCOS, and 35 years 150 U in PCOS. And we can increase the dose according to the age group and ovarian characteristics. And one important point is, this is only for guidance, but every patient should be analyzed, and gonadotropin dosage should be tailored according to their needs and characteristics and ovarian response. In PCOS, the most preferred regimen is chronic step-up regimen, where we use very low dose of, we start with very low dose of FSH, that is 37.5 or 75 U. With close monitoring at weekly intervals, we see for the follicular response. If the follicle, there is no dominant follicle, that means if the ovarian follicle is not more than 1 centimeter, we continue the same dose for another week and we see for the response. If we see the follicular response, we continue the same dose till we get follicular maturity. If we don't see any response, we escalate the dose by 37.5 or 75 U, depending upon the ovarian response. And we continue the same escalating doses till we get the follicular response. Once we see either weekly or bi-weekly, we escalate the dose. Once we see the follicular response, the same dose will be continued till the follicular maturity, till the triggering of the follicle. And in step-down protocol, this chronic step-up protocol induces monofollicular development. It's much safer and most preferred regimen in the PCOS, but it's a prolonged regimen, and it tests the patience of both the physician and the patient. One should be really patient with this regimen to get good follicular response. One follicle is stimulated, that will be in general monofollicular in nature. And coming to step-down protocol, the initial dose used is 150 to 225 U needs, but this protocol needs intense monitoring and experience to manipulate the dose according to the follicular response. Because suddenly, when the threshold is reached, we can get large cohort of growing follicles. So one should be really vigilant about this follicular response. We have to monitor very closely through ultrasound, and we need experience also to manipulate the dose. And the multiple pregnancy rates with various regimens are clomiphene citrate is around 5 to 10%. We see mostly twins. And letrozole is and the incidence of multiple gestation is slightly lesser than clomiphene citrate, but studies showed similar rates. And again, mostly twins we see. And conventional step-up protocol is associated with high number of multiple high-order pregnancies. The incidence is around 15 to 36%. Nowadays, conventional step-up we don't use. And step-down protocol, the incidence is around 10%. And low-dose step-up protocol, we can see here, because it is most of the times associated with monofollicular growth, the incidence of multiple gestation is only 6%, which is acceptable. So precautions in GnRH, gonadotropin-induced cycles, there are points to remember. Start with low dose and step up by low dose, that is 37.5 IU or 75 U. And we have to remember that response can be sudden and explosive when the threshold level is crossed. Suddenly we'll see large cohort of growing follicles, in which case we have to counsel the couple regarding the possibility of going for a ovarian hyperstimulation, and we can offer them rescue IVF cycle. But if the couple do not want to go ahead with rescue IVF cycle, we have to caution them. We have to advise them regarding strict abstinence for fear of landing up with the severe ovarian hyperstimulation. And also we have to tell them to come back if there is any signs and symptoms of ovarian hyperstimulation, that is abdominal distension and breathlessness. Typically, woman comes back on day 7 with breathlessness and abdominal distension, in which case we have to rule out ascites and pleural effusion. So one must have thorough knowledge regarding the signs and symptoms of OHSS, and also knowledge regarding the treatment of OHSS. So and also we have to have either the link up or backup for the rescue IVF also sometimes. And use of gonadotropin should be only taken up when there are proper monitoring facilities are available. So these are the points to be remembered. And if you stick to lower doses, generally these problems won't arise. But this response to gonadotropins is unpredictable from person to person, and also the same person from cycle to cycle. So we have to be really cautious about the gonadotropin, monitoring of the cycles when we are using gonadotropins. And coming to usage of gonadotropin, GnRH agonists and antagonists, and 25% of the gonadotropin induced ovarian stimulation cycles are associated with premature LH surges. So many physicians that try to use GnRH agonists and antagonists to prevent premature LH surge. But in general, GnRH agonists are not combined in IUI cycles for the fear of inducing multifollicular growth and increased requirement of the increased doses of gonadotropins. So generally we don't use GnRH agonists in IUI cycles. Coming to antagonists, again, as I said, this is used to prevent premature LH surge. The use of antagonists definitely decreases premature LH surge, but studies did not consistently show the increased pregnancy results with the addition of the antagonist. This could be because of lack of, again, proper randomized control studies. And its use may be justified in gonadotropin-induced cycles when there is history of previous cycle showing premature LH surge. When the woman is showing premature LS surge and premature unexpected rupture of the follicle or premature luteinized follicle, then we can think of using GnRH antagonist in the next cycle. And also, when you think if the follicle needs more maturity, that if the endometrium is not good enough to induce ovulation, if the perifollicular flow is less than expected for your triggering, then we can give antagonist and prolong the follicular phase. One more advantage with prolonging the follicular phase is we can get more number of follicles reaching the follicular maturity, which again gives us more number of oocytes available, fertilizable oocytes around ovulation, which in turn can increase pregnancy rates. Then that is another advantage suggested for use of GnRH antagonists. And also we can avoid weekend IUIs by adding GnRH antagonist instead of Sunday, we can do the IUI on Monday. So that's how we can, these are the suggested kind of situations where GnRH antagonists can be used. But as of now, not many studies are in favor of GnRH agonists combining with IUIs to improve the pregnancy rates. When you use antagonists, we have two preparations, injection ganirelix and cetrorelix. The doses being 0.25 mg subcutaneously when follicle reaches about 14 to 16 millimeters in diameter. You can continue the injections till trigger. It may require 2-3 injections. And conclusion regarding ovarian stimulation along with IUI after reviewing 43 trials are significantly higher pregnancy rates are seen with gonadotropins, and there is no significant difference between CC and letrozole in terms of pregnancy rates, and no significant difference between type of the gonadotropins used, whether you use the urinary gonadotropins or recombinant FSH. There is not much of difference in the pregnancy rates, and there is no additional benefit with the addition of the GnRH or agonist. As I said earlier, there is not many studies are in favor of using or adding agonists or antagonists in IUI cycles. And though many protocols are available, individualized cost-effective protocol is ideal for IUI cycles. And that means the protocols must be individualized in each person, and it varies in same person from cycle to cycle. And multifollicular growth is associated with high pregnancy rates as expected. And studies showed that chance of pregnancy is 5% higher with 2 follicles and 8% higher with 3 to 4 follicles. And multiple pregnancy rates with the number of follicles as follows. 2 follicles increase the risk of multiple gestation by 6%, and 3 follicles the risk is increased by 8%, and 4 follicles the risk is increased by 14%. And clinical pregnancy rates with monofollicular cycles expected is 19.7%. When compared with multifollicular cycles, the pregnancy rates are increased by 29.4%. In essence, more number of follicles, more chance of multiple births, and as well as pregnancy rates. So cycle cancellation criteria, when you see more than 3 mature follicles of 16 millimeter size at the time of trigger, it's an indication for cycle cancellation. That's how we can prevent multiple births associated with IUI and ovarian stimulation. Timing of triggering, in CC and letrozole cycles, trigger can be given when the follicle reaches about 18 to 20 millimeters. We can wait up to 22 millimeters also if the endometrium is not good enough. And gonadotropin induced cycles trigger can be given around 17 millimeters because gonadotropin cycles are associated with increased levels of estradiol, which can raise natural LH surge. To prevent that, we trigger the follicles around 17 millimeters. And regarding endometrial thickness of 8 millimeters with trilaminar pattern is very important for implantation, and thickness less than 6 millimeters or hyperechoic endometrium on the day of HCG are associated with lower pregnancy rates. The left side picture is showing typical trilaminar pattern endometrium around the ovulation time, and the right hand side is showing hyperechoic endometrium, which means the progesterone is already rising. That indicates premature luteinization of the follicle, which is not good for implantation. And coming to the role of ultrasound and Doppler studies in follicular tracking, right hand side is showing perifollicular flow, which is good enough. It's covering almost complete circumference of the follicle, that we can call it a pre-HCG follicle ready for ovulation. And left hand side picture is showing good endometrial flow, and endometrial flow and perifollicular flow can be assessed by Doppler very well. So color Doppler can assess the maturity of the follicle. And when the follicle matures functionally, the Doppler demonstrates blood vessels covering at least 3/4 of the circumference of the follicles. That means the follicle is mature enough, ready for triggering. Good perifollicular flow in pre-HCG follicle with peak systolic velocity 10 centimeters per second with low resistance indices predicts good rates of conception. So this is routinely how we assess the mature follicle with the Doppler. And it is suggested we can withhold HCG if you don't have proper, if you feel if you don't have proper good perifollicular flow, and if the PSV is not optimum, so we can withhold HCG till we get proper perifollicular flow and PSV to get good pregnancy rates. And again, we can assess the endometrial flow with Doppler, which can predict the implantation rates of the in pregnancies. And the zones of vascularities are defined according to Abelbaum classification. And zone 1 is called when the vascularity is seen only at endomyometrial junction. Zone 2 when the vascularity reaches hyperechogenic endometrial edge. And zone 3 when the vascularity reaches intervening hypoechoic zone. And zone 4 when the vascularity reaches endometrial cavity. So markedly better conception rates are seen with zone 3 and 4 endometrial flows. So this we routinely follow before embryo transfer in IVF cycles. These studies we generally do before embryo transfers. Regarding timing of insemination, rationale is to have viable sperms during ovulation. And to achieve optimum fertilization, insemination should be done as close to the ovulation as possible, ideally between 24 to 48 hours. And the points to remember is ovulation occurs between 24 to 56 hours after natural LH surge, but ovulation occurs at around 32 to 36 hours after HCG injection. And mature oocyte is fertilizable only for 12 to 24 hours. Hence, ideal time is to inseminate around 34 to 36 hours post HCG injection. Endometrial scratch studies did not support the role of endometrial scratch to improve implantation rates. And these are the various triggering agents used for triggering ovulation. Urinary HCG in the dose of around 5,000 to 10,000 IU, and recombinant HCG 250 micrograms subcutaneously, decapeptyl 0.1 mg subcutaneously, leuprolide 1 mg subcutaneously, boserlin 0.5 mg subcutaneously are enough to induce ovulation. In IVF cycles, we do combine both antagonist plus HCGs to improve the mature oocyte quality and also good luteal phase. Timing between another important factor which can really affect the IUI results are timing between the semen collection, preparation and insemination. Semen collection should ideally be done at the clinic and there should not be any delay between the collection and the preparation, and semen processing should be started within 30 minutes of the ejaculation, where that means it is possible only if the semen is collected at the clinic or if the person can bring the semen sample within 30 minutes after ejaculation, because prolonged exposure of spermatozoa to the seminal plasma can decrease the motility and the viability because of the various substances present in the seminal plasma such as dead cells, leukocytes, antigenic proteins, prostaglandins. They can all damage the membrane of the spermatozoa, which can decrease the viability and motility of the spermatozoa. And IUI should be done. Next important point is IUI should be done within 1 to 2 hours of semen processing to get best results, because again if the after semen wash it brings about certain changes in the acrosome of the sperm which initiates capacitation and which leads to progressive decrease in the due to in the motility of the sperm because of the exhaustion of the energy sources, thereby decreasing the fertilizable spermatozoa. So because of the after capacitation, the energy sources present in the acrosome, they start getting exhausted, and which can lead to decreased decreased motility of the spermatozoa, which can decrease the fertilizable spermatozoa. So within 1 to 2 ideal time is to inseminate within 1 to 2 hours after semen processing to get the best results. So these are the semen parameters cutoff values to opt for either to go for IVF or ICSI. We have already discussed about these parameters. Inseminating motile sperm count must be 1 million and sperm morphology must be more than 4% in the normal native sample. Total motile count in the native sample ideally be 5 to 6 million, and total motility in the native sample should be more than 30% to go for IUI to get best pregnancy results, good pregnancy results. Coming to semen preparation techniques, again the aim of the semen preparation we all know to get highly motile capacitated morphologically normal spermatozoa free of infectious agents, antigenic proteins, dead sperm, leukocytes, immature germ cells, which can lead to production of ROS when spermatozoa are exposed to seminal plasma for long hours. And inseminating raw sample can create pelvic inflammatory disease and can cause painful uterine contraction. It should be avoided at any cost, and that's because of release of prostaglandins. So available semen preparation methods for IUI treatments are simple wash and centrifugation, density gradient method, swim-up technique. And systematic reviews of RCTs did not support any particular method over the other for the semen preparation in IUI cycles. In IUI cycles, and choice should depend upon the quality of the native sample. If the quality of the native sample is good enough, we can opt for a simple swim-up technique. If the quality of the semen sample is compromised, native semen sample, in order to get a good and quality spermatozoa, it is better to opt density gradient method. And time of the centrifugation is more important than centrifugal force, and the time should be kept to minimum. And as I mentioned earlier, time of the centrifugation is more important because longer longer the duration of the centrifugation, it may generate ROS, that is reactive oxygen species, which can damage the sperm membrane. Inseminating volume, optimum volume of the inseminate should be kept between 300 microliters to 500 microliters. Higher the volume, more chance of backspill, and very low volume, that is less than 0.2 ml, may not compensate the dead space in the cannula, which can make the IUI difficult. So regarding number of insemination, again, this is also very much debated. Number of inseminations can be done either single time or twice around the time of ovulation. But most of the data support single insemination done around 34 to 36 hours post HCG administration. But some of the studies showed that advantage of double inseminations, especially in male factor infertility. Double insemination when done, generally first insemination done around 24 hours post HCG, and second insemination done around 48 hours second sample. And double insemination may increase the stress of the couple both psychologically and financially for the marginal benefit. Hence, we have to decide and depending upon the etiological factors, and also we have to counsel the patient regarding the financial burden. Factors affecting the success rates of IUI during insemination are use of tenaculum during the insemination, uterine sound, touching the fundus during insemination, back spillages, blood on the tip of the cannula, abdominal cramps or spotting post IUI, and all these factors may decrease the results of IUI. So we have to be as gently as possible while doing insemination. And type of catheters available are soft or rigid, disposable or metal. Ideally, catheter should not be too soft or too stiff. It should be firm enough to negotiate the cervical canal without any difficulty. Generally, I use D1's catheter, which is good enough for IUI cycles, many IUI cycles, and very difficult when tightly closed internal loss, I use Meckler's cannula. Cochrane review of 9 trials did not support any particular catheter. Doing insemination as gently as possible in more dramatic manner improves the results of IUI. And procedure during procedure of IUI, we do like this, and we'll make the patient to lie down in the lithotomy position. We have to wear non-toxic gloves, and we'll check the label again on the sample regarding the particulars of the partner, and we have to check it thoroughly, because if you are doing 3-4 samples at a time, then if you are handling 3 to 4 samples at a time, there may be a chance of confusion. So we have to always check the sample, label on the sample before we go for insemination, and use cusco speculum instead of Sims and tenaculum. Gently we have to expose the cervix, gently remove the mucus from the external nas with the cotton swipe soaked in normal saline, and use soft cannula, just pass above the internal nas, and fundus should not be touched. Even if you touch the fundus, wait for 1 or 2 minutes to get contractions to get subsided, and inseminate slowly over the period of 1 to 2 minutes. Apply pressure on the piston till we remove the cannula to avoid the backflow, and avoid blood staining as far as possible. Make her lie down for at least 15 to 20 minutes. These are the important points to improve the results of IUI. And abstinence also, many couples they ask about the abstinence during the period time of IUI procedures. And as fertilizing capacity of the washer spermatozoa is only 2 to 3 hours, there is nothing wrong if the patient continues to have intercourse, and unless it is male factor related problem, in which case we ask the patient to have abstinence to improve the spermatozoa number in the seminal sample for the semen preparation. Another question often asked is immobilization after IUI. In fact, sperm reaches fallopian tube within 5 minutes after insemination, but the studies have shown that significant improvements in cumulative ongoing pregnancy, cumulative pregnancy rates, that is 27 versus 18%, and live birth rates 27 versus 18%, were reported after 15 minutes of immobilization versus immediate mobilization. So it is better to advise the woman to lie down at least 15 to 20 minutes post IUI. Coming to luteal phase support, except in gonadotropin stimulated IUI cycles, other cycles done with CC letrozole or combined CC letrozole with gonadotropins do not require any kind of progesterone support. If you are opting for progesterone support, ideally is natural vaginal micronized progesterone, which is the cheapest way of luteal support in gonadotropin stimulated IUIs. Generally, 200 milligrams BID vaginally is sufficient, but in case if the woman is intolerant with vaginal preparation, we can give her a prescription of dydrogesterone, which is another very good luteal phase support in the dose of 10 milligrams BID for 10 days. Complications of IUIs, infections. In well-conducted IUI, chance of infection is negligible, and multiple gestations and incidence of ovarian hyperstimulations are related to ovarian stimulations. When we go for milder stimulations and with the strict cancellation criteria, we can avoid both these complications. So why IUI fails? Poor patient selection, improper IUI, poor semen preparation technique, failure to maintain time from ejaculation to insemination, faulty techniques are difficult IUIs, poor oocyte quality, subtle tubal dysfunction which may not be revealed in HSGs, and non-receptive endometrium. And counseling, regarding counseling, which is an important aspect of any ART procedure, IUI also needs proper counseling. The procedure, before we go for IUIs, we have to counsel the couple. And as infertility is a stressful condition for the couple, both financially, physically, psychologically, and they expect result from every cycle. So proper counseling must be given regarding the success rates, expenditure, requirement of repeated attempts, and other treatment options. And proper consent must be taken in writing before going for, must be obtained from both the partners in writing before we go for IUIs, especially in donor insemination. Consent from husband is must. So, who is the ideal couple for IUI treatments? Female partner age less than 35 years, duration of the infertility is less than 4 years, unexplained ovulatory secondary and mild endometriosis cases and mildly compromised male factor cases, and when the basal FSH is less than 7 IU per liter, patent tubes, motile sperm, total motile sperm count is, if it is between 5 to 10 million, and morphology, if it is more than 4%, DFA is less than 30%. A couple with these characteristics are ideal for IUI treatments, and they get good results. So conclusions are proper evaluation of the couple followed by right protocols, monitoring, insemination techniques should definitely increase the success rates in IUI. Though IUI is still not considered as an effective tool to be offered as first-line therapy to treat subfertile couples, because of its simplicity in technique, inexpensiveness, IUI should be tried as first choice in properly selected subfertile couples. Well-controlled mild IOS with gonadotropins aiming two dominant follicles is the most effective strategy when performing IUI for unexplained infertility, minimal to mild endometriosis, and moderate to mild male factor infertility. Thank you. So thank you all for your patient listening. Over to Dr.
Thank you,
Stalin.
ma'am. Yeah, ma'am. Thank you, ma'am. Thank you for that very much informative session, ma'am. And it's always a honor to hear you, ma'am. With your presentation, ma'am, we can able to understand that IUI is less expensive, less invasive, and comparably effective for patients as a first-line treatment for couples with unexplained or male factor infertility. So hope the participants found this session useful. And madam, if you allow us, then I will read out if there is any questions in the comment box.
Yeah, sure.
Yeah, ma'am. Let's wait for 2 or 3 minutes for the participants to post their queries, ma'am.
Yeah, sure.
And madam, what will be the impact of these PCOD patients when they come for IUI, ma'am?
As I said, mentioned in one of the slides earlier, PCOS patients anovulation per se is not an indication for IUI, but because they take lot of pains in attending clinic for IUI, I mean, it takes prolonged duration to get them stimulated, to get proper follicular growth. We often combine IUI in these patients to get optimum results. As such, PCOS patient is not an indication for IUI, because they'll have if they have patent tubes and normal male factor, they conceive naturally once they get good follicular response.
Okay, ma'am. Ma'am, how many cycles do we usually recommend for, ma'am, for a couple? Is there any numbers, specific numbers?
Yeah, that was also mentioned in my talk. Ideally, we can do up to 4 to 6 cycles, because up to 6 cycles, IUI is still cost effective than IVF. After that, in general, first 3 cycles, the pregnancy rates are good enough. And if you can go on doing IUIs with more number of and for more number of cycles, studies have showed that pregnancy rates didn't improve after 3 to 4 cycles, and pregnancy rates plateaus down after 3 to 4 cycles. So there is no point in continuing beyond 3 to 4 cycles. Ideally, 3 to 4 cycles. But up to 6 cycles, it is cost effective when compared with IVF cycles.
Ma'am.
So
yes, ma'am, I'm waiting for the participants to post their comments, ma'am.
maybe there are no
Yeah.
doubts.
Ma'am, is there any special semen preparation techniques which can boost?
Yeah, I mentioned earlier for normal semen sample with normal semen parameters, simple swim up technique is enough. But if the semen parameters are compromised, to obtain good number of good quality spermatozoa, we better opt for density gradient. That's enough in IUI cycles.
Yeah, yes.
So
Yeah, ma'am. Yes, ma'am.
if
So
there are no doubts.
yeah, ma'am, I could not find any other questions in the chat box.
Okay,
So if
okay.
you all us, then we can
Yeah,
end
yeah,
this
we can.
webinar from today. Ma'am.
Yeah.
So
Ma'am,
thank you
good
very much, ma'am. Thank you
Uh,
very much for your presence and spending your valuable time with us, ma'am. Thank you.
Thank
Ma'am,
you.
good evening, ma'am. PV Prasad, Janisya.
Oh, okay, yeah.
Thanks so much, ma'am, for
Hello.
honoring our request and being there for us today.
Yeah, thank you so much for
I've been
giving.
traveling, so I couldn't indeed, be there in the beginning. There was no good signal.
Okay. So
Ma'am.
voice is quite audible, right? My voice. So
Yes. Thank you, ma'am.
okay. Okay then.
Thank you,
Okay
ma'am.
then. Okay
Thank you
then.
so much,
Bye
ma'am, once again.
everybody.
Yeah,
Bye
thank you,
everybody.
ma'am. Thank you, ma'am. Thank you all the audience for logging in.
Okay.
Thank you very much, ma'am.
Okay then. Thank you very much.
Thank you very much, ma'am. Thank you, ma'am.
Okay then. Bye.
Bye. Thank you.
Bye.